I think another very important study, which has already been presented a few days before at ASCO, has been presented by Paul Richardson from Boston, from Dana-Farber Cancer Institute, Boston. And this is the prospective randomized trial comparing VRE plus minus autologous stem cell transplantation followed by Revlimid maintenance in newly diagnosed patients with multiple myeloma. The study is called the Determination trial and follows the same study concept which has been used by the IFM, International, the Intergroup Francophone Myeloma. They used a similar, very similar protocol with the exception of the maintenance treatment, which in France was limited to 1 year, and in the US study, maintenance is until progression or intolerance with lenalidomide. So the question is, what is the benefit of autologous transplantation in newly diagnosed patients? And when they looked at the outcome of those patients with very good response, I think there was, of course, a slightly improvement in the quality of response in the transplanted patients. And the important information is that not only the quality of response was better in patients transplanted, but also the progression-free survival, namely 67.6 months versus 46.2 months. So a difference of about 20 months in progression-free survival. And patients were then who relapsed were then scheduled for the non-transplanted patients that relapse should receive a transplant at relapse, but only a small minority received the transplant, I think 22%, and all the other patients who relapsed in the arm without transplant received other conventional chemotherapy. Actually, when we looked at overall survival, there was no difference between both groups. So these data indicate that you have a choice. If you are standard risk patients, you have a choice between obtaining an even deeper response and longer progression-free survival with the burden of autologous transplant, which impairs quality of life for a few weeks and months, or you try to omit this burden and just go for VRD and then for maintenance therapy. The outcome is similar in terms of overall survival. And the reason for this similar outcome is probably that patients who have received the transplant before and enjoy a longer progression-free survival have a shorter survival, a progression-free survival after rescue treatment. So the benefit which you obtain after first-line treatment is lost when patients relapse and need a second-line treatment. So both together add up to a similar overall survival. What is still not disclosed in the abstract is that the outcome of patients with high-risk cytogenetics, because we know that patients with high-risk cytogenetics tend to benefit not only in terms of PFS, but possibly also in terms of OS from a transplant. So we need to see and wait whether this data will be presented as well. But for the time being, the data just indicate that patients have a choice between a less aggressive and or let's say limited aggressive treatment period. Both treatments render similar outcomes when it comes to survival, and when it comes to quality of life, there's only a short disruption of quality of life in patients with transplant, which is of course inherent in the procedure, but then quality of life improves and is similar to those who did not receive or do not receive a transplant. The second primary malignancy rate was similar in both arms and was 11%. So I think that is very important for clinical decision making and talking to patients. And I'm sure this study will be frequently referenced and will foster further discussions within the myeloma community. With that saying, I would like to thank you for your attention, and I close here. Thank you very much.